afternoon. Well, good morning. Afternoon now. It's afternoon now. I'm Dr. Ijoma. I'm a practicing OBGYN in Nassau, Bahamas, and I am more than delighted to moderate the third session of this research day. I want to say a thank you to Dr. Halliday and all the other organizers um, that have basically gotten this on board. I think that they're doing an excellent job so far, and I just want to say thank you to them for this. This third session that we will be starting is entitled Reproductive Health. And we will first start this session with our keynote speaker, Dr. Vishal Bahal. He started his medical training, but he is a practicing OBGYN oncologist in Trinidad and Tobago. He started his medical training at the University of the West Indies, where he obtained his MBBS. He then started to work at the San Fernando General Hospital, where he completed his internship, after which he then went on to do his residency in obstetrics and gynecology, where he obtained his postgraduate degree from the Royal College of Obstetricians and Gynecologists. He then went on to subspecialize and obtained a fellowship in gynecological oncology. And he obtained this in Northern Ireland, where this was actually accredited by the European Society of Gynecological Oncology. He is a trained colposcopist by the BSCCP, which is the British Society for Colposcopy and Cervical Pathology. He is keen on minimally invasive surgery pertaining to gynecology in particular. He is also keen in advanced cytoreductive surgery for ovarian cancer. With all of this wealth of knowledge, he is determined to give back. And thus, he is an associate lecturer at the University of the West Indies. He's also a consultant, an obstetrician, gynecologist, and oncologist in Trinidad and Tobago, where he offers services in both the private and public sector. Please join me as I welcome Dr. Bahal as he starts his talk. And he will be speaking on the implementation of HPV, which is the human papillomavirus, testing as a primary screening method for cervical cancer.
Right. So my job today, I'm presenting an HPV pilot study that we conducted in Trinidad and Tobago. Just some background to that is that right now in Trinidad and Tobago, we have cervical screening using conventional smears in the public sector, whereas privately we do have HPV screening that is either primary HPV screening or even using liquid-based cytology and using HPV as co-testing. But publicly, all we have is conventional cytology. So we decided to conduct a pilot study in one of the hospitals in Trinidad and Tobago. This is in the NWRHA, the Northwest Regional Health Authority. So we decided to conduct this study in order to determine the feasibility of implementing or rolling out primary HPV testing for cervical cancer. So what I will do is go through the introduction, the objectives, methods, results, and conclusion. My presentation shouldn't be too long, so I'm hoping to keep within the time. So as we all know, the sequelae from developing the pap smear to linking HPV to abnormal smears. So it started in 1941. We had the link between HPV and abnormal smears in 1992. Then we developed the first vaccine in 2006. And then from there, we eventually, in 2014, it was FDA approved first HPV DNA test for primary cervical cancer screening. This is just a slide. Again, most of us know it does take a long time to go from an HPV infection to pre-invasive disease to cancer. And that's why we know if a patient has, screening, you can actually prevent cervical cancer. And with the combination of vaccines and screening, the hope is to eventually eradicate cervical cancer. Now, it is still a significant burden in developed and developing countries. Now, this graph, as you can see on the first column, you can see the new cancer estimates in developed countries when they compared in the light blue 2012 to 2025 projected. It's expected to stay, fairly stable. However, in less developed countries, you can see that we are expected to have an increase in new cancer estimates for cervical cancer. And again, this is reflective on maybe our poor screening methods, or it hasn't taken off and should. With regards to deaths from cancers of the cervix in developed countries, again, relatively stable and expected to be that way. However, in less developed countries, we're expected to have a jump in 2025. So this is just to show there is a significant burden in developing countries and is expected to increase. So we have to do something in order to improve our screening to decrease the risk of cancers. Now, with respect to Trinidad, this graph shows we do have an increase in cancers of the cervix even above the age of 65. And this shows we do have patients dying above the age of 65. And again, it is just to show that it is reflective on the fact that we don't screen, and patients sometimes present late on and do present with advanced cervix. And as a result, we have a higher mortality. This is a busy slide, but just to show that on the left-hand side of your screen, we have the more developed nations. And in the green, you can see that's the effective coverage for screening. Whereas in the red, it shows that that's patients who have never had a pelvic exam. And the blue is a crude coverage. But in developed countries, you have, cervical cancer rates can go from, sorry, I should say screening can go from 63% in developed countries compared to 1% in Bangladesh and other countries to the right. So we do know that basically we have a lot to catch up on in a lot of the developing countries and where we should be aiming to get to. With respect to HPV, and I included this slide because it's relevant to what I'm going to talk about in a bit, is that we know that HPV 16, 18 are associated with higher grade abnormalities. So if you look at the line graph on the left-hand side of your screen, you can see that it's associated with high grade changes in cervical smears, and then that corroborates with severe pre-invasive disease when you look at HPV 16 and 18. So there's a high incidence of severe pre-invasive disease when you look at CN 2 and 3 for HPV 16. And there is also an associated with HPV 45, and some countries, Caribbean countries, have found a higher incidence of HPV 45, especially in countries like Barbados, where they had some studies done. In the Caribbean islands, as I was saying, we have little data available on the HPV subtypes in Trinidad and in a lot of the Caribbean countries. But we do have some Caribbean countries that did some tests with regards to the subtypes of HPV. And you have high-risk HPV types such as 52, 35, 51 were common in St. Kitts and Nevis, St. Vincent and Grenadines. You have 45, 35, 31. So it is important that we adopt primary HPV screening, and if we can, identify the types. That's an added bonus. So we can now have this data, which is very important in treatment and maybe picking up HPV-related diseases in the future. As I was saying before, Barbados, they did a study with 413 women, and they actually found HPV 45 was more common compared to 16 and 18. So, as I said before, we do have screening in Trinidad in the public sectors, conventional spheres, private HPV liquid based, and we do have. I just added in we do have vaccination available in both public and private. So, from what I've said before, we do know HPV testing has been shown to be more sensitive at detecting CIN2 plus, adenocarcinoma, and in situ, as well as cervix cancer. And a negative HPV, it offers a higher protection against the development of cancers of the cervix. So this would allow for increased screening intervals, which is more cost effective in the long term. And I use the word long term because in the short term, it is a higher cost in the short term, but it will even out in the long term. And as well, the aim would be to decrease cervical cancer, which it will do that. We do know that 16 and 18 has a higher association with high-grade pre-invasive disease. And I added in, again, to reiterate, we do have a lack of local data with regards to the incidence of the HPV 16 and 18. So our objective was to assess the feasibility of HPV DNA testing as a screening tool for cervix cancer in the public healthcare system. So I will go through the methodology, which would be the overview, the sites we use, sensitization, recruitment, lab, and the algorithm that we used. So essentially in 2018, PSI Caribbean was a non-governmental, non-profitable organization partnered with the Ministry of Health and the Northwest Regional Health Authority to conduct this HPV DNA testing pilot project. The target was 1,500 samples. However, we were only able to get 1,305 samples. And again, this was during COVID, but some of this took place, and there were a lot of challenges, which I will mention a few of in the upcoming slides. This was conducted over March to October 2019. The samples were processed at one lab, and we actually used a K-HPV testing machine, because this is what was given to us or loaned to us. And all women who received an HPV positive results were referred for further follow-up. So prior to this, we would have met with all the stakeholders, developed the algorithm, we confirmed which sites would be done, which sites would be used to collect samples, meaning test patients. We decided on the target number of patients required, and the infrastructure. This is where we decided number of kits to order, staff required to conduct this testing, the appropriate training and appropriate training for both lab staff together with doctors, nurses, clerical staff in carrying out this project. So we used 18 health centers across the NWRHA, which is in the northern part of Trinidad. HPV testing was offered on the same day that clinics offered pap smear testing. So patients would come for a pap smear, they would then be consented for this HPV test, they would be given written material, and they would decide if they'd like to be enrolled and have this test done. And ethical approval was given by ministry. We sensitized the physicians, where the staff at NWRHA, we sensitized the physicians, nurses, interns at primary healthcare centers and occupational health departments. The protocol and the algorithm was provided both in soft copy and hard copies for the health centers and all the staff involved in screening. And again, training of staff was conducted by staff within the ONG department for gathering samples. The lab staff was trained by that was done separately. That's for the testing of the specimen. This is a sample of the information that was given to patients, and patients were also signed consent. So patients were recruited as they visited the health centers, as I was saying, patients with 30 to 65 who fit the inclusion criteria. Patients were asked if they would like to participate, and consent was given, and the sample was collected in the gynecological exam. So eligible women was essentially the entire population of women within the NWRHA, women aged 30 to 65, ideally first-time screeners with no previous smear tests, and basically they did not have any abnormal smears. If it was not their first smear, they did not have any abnormal smear within the last 6 months. Exclusion criteria: pregnant patients were not screened, women known to have HIV or any sexually transmitted infections, women known to have undergone a hysterectomy. The testing algorithm, I will go through that. I have a slide with just a picture of the algorithm. Essentially, when a patient, so I will just go through this algorithm here. When a patient received an HPV test, if it's negative, they would return for routine screening in 3 years. Now, just a point about that, we know that with primary HPV screening, you can actually screen every 5 years. But because this was new, it was a pilot project, and it was in a population, our population was never been done before, we sort of decided to leave routine screening as every 3 years in order not to miss some of these patients and just to have a closer follow-up. If the patient had an HPV high-risk subtype positive, they would go on to have a smear done. If HPV 16 or 18 was positive, they go directly to colposcopy. Now, this algorithm was developed for a machine or HPV testing machine that could have given us 16 and 18 separately. But as I would mention later on, the KHPV machine actually tests for all the high risk, including 16 and 18. So it just gives us a positive or negative. So it did not essentially give us a 16 or 18. So all the patients who had a positive actually underwent a smear. And if you had, as from the algorithm, if it was normal, you were rescreened at 12 months. If it was high grade or low grade, you'd be referred to colposcopy. These samples were analyzed, as I was saying, using the KHPV testing machine, and this detects the presence of 16, 18, 31, well, these listed out here, and the results are either positive or negative. So, with regards to the results, a total of 1,306 women were tested, and 1,201 women were eligible. Now, there were issues with, we didn't achieve the 1,500. That was because a certain number of kits were ordered. We ordered extra, but then there were damaged products. There was issues in reordering some of the kits because during COVID, then why less patients were eligible, as I was mentioned before as well, they didn't fit. So some of the training of the staff, even though they were trained, we had a lot of issues where staff had to be reshuffled around due to COVID, and we had to retrain staff on short notice. Some people would have screened patients that fell out of the eligibility criteria. For example, a 25-year-old or patients above 65, and a lot of these patients had to be excluded, and some of them were inadequate samples, and that resulted in less patients as well. So total samples tested with 1,241. As I said, 22 didn't meet the criteria. 1,201 were eligible, and out of these, we had 140 that tested positive. So our HPV positivity rate was 11.7%, which is comparable to international studies as well. Now, this graph would show in the 30 age group. So this is 30 to 39 age group. This is the number of patients that were tested, and the gray column would be the percent of positives. So this would be 15% of the patients within the 30s were positive, 9% in the age group that was in the 40s, and 8.5 and 8.7 in the 60 to 64 age group. And our overall positivity rate was 11.7%. So with regards to the summary of referrals for these patients, so as I was saying before, all the positive patients were referred for a pap smear, and out of these, the pap smears that were abnormal were then referred to colposcopy, and this number was 36. Now, they had a significant number of patients we weren't able to contact or who simply did not come back in the projected time period. And this is a problem again when you're testing HPV and you're calling back patients to do a pap smear, which I will mention in terms of what are recommendations for the future. So out of these patients, 9 underwent a LETS procedure, 19 underwent biopsy. And you can see this is a chart showing the distribution of the abnormal pap smears that were received when patients were referred for cytology. So you can see, and this the different colors over the age groups. So just to mention, in the high grade age, for high grade smears, we had a total of 12 patients who had a high grade smear. We had 3 patients who had low grade smears, and we had ascus. Then we had a couple of patients who had a cervicitis. 1 patient had invasive disease. So this was the distribution of the type of smears they received. With regards to the positive HPV who were referred and had CULPs, so you can see that a little over half of them had either CIN 2 or 3. So, and 8 of them had CIN 1. There were some patients with cervicitis, and a couple of patients were unreachable when they were referred for colposcopy, and as well as 4 appointments were pending by the time the results were going to be presented. So, regards to the discussion, so again, the purpose of this pilot study was to determine the feasibility of implementing, primary HPV testing, and to sort of identify challenges and possible issues that could result in a rollout of HPV testing. This was the first opportunity for women in Trinidad to access primary HPV testing in the public healthcare sector. That's important to know. And it is also important to know that the WHO recommends that, heading in the direction of cervical cancer elimination, 70% of women should be screened by high performance test by 35, and again by 45 years of age. So, in our quest to achieve this, the plan eventually would be to roll out primary HPV testing. Now, with regards to data on local data, we don't have any data with the actual percentage of women that are screened locally, but we do know that it's a small number based on our population and how many smears the different regions do, as well as how many smears that the private sector do. But we have no hard evidence, but more anecdotal evidence from small audits and different from the different regions. But we can all agree that we do have a problem, as I showed, from the burden of cervical cancer in the internationally and in developing countries, and in Trinidad and Tobago, we have about new cancers of the cervix every year, and our population is about 1.4 million. And we still have over 110 people dying from cancer of the cervix every year. So we do know it's a problem, and we need to do something. So basically, this pilot study, allows us to see what potential issues and hiccups could have arisen from our pilot project and how we can go about fixing that. It also demonstrates the feasibility and the positivity rate, which is about 11.7%. And it is also important to note that we do expect, and any study will show you that there will be an increase in colposcopy services. But the cost savings, the long term, will come about when there is an increase in intervals of screening, in the long term. So some of the challenges we encountered is, one, training. We realized that we had problems with staff issues where you had to train and retrain persons because staff was being redirected to COVID facilities, and that was a big challenge. And hopefully that doesn't happen in the future. We were short-staffed as a significant number of times. Equipment, as I was mentioning before, there was faulty equipment. We had to reorder. That took some time. Then appropriate educational information in the initial period not everything was available, and then we had to reorder. So, and then we had to actually retrain some of the staff who were taken away in order to counsel patients appropriately. Patient follow-up was a big problem where some of these areas, patients go for a smear, they were explained and they were counseled that after this HPV test, if it's positive, they may be called back for a pap smear. But again, some of them didn't return, and then they were confused. Well, they had a test. Why they come back? A lot of them did understand and come back, and some people contact numbers they didn't answer their phone. So those are some of the issues with regards to follow up. Some of the corrective measures I'll mention later on. So recommendations. So patient referrals and follow-up. Now, going forward, there were some ideas where a smear could be, if we look at the cost for doing a smear at the same time of as an HPV test, using these machines, you can actually do a smear at the same time to avoid patients having to come back and only process that smear if the HPV test is positive for other high-risk type. The other thing is that we'll be using the gene expert, which we should give us 16 or 18 positive. So if it's 16 or 18 positive, we wouldn't process the smear. So again, we can decide based on speaking to some of these patients, if they counsel appropriately, who can actually be brought back or who would agree to come back, or some of these patients, depending on where they live and where they're from, if you can possibly do it at the same time. So we're looking at those solutions for that problem. With regards to information, education, and communication, we have developed more different methods of educating the public with regards to the same info, and that would be having patients receive soft copies via email, or even having it on the websites as well. We do need to have a proper management information system, meaning an electronic information system, so that there is no lost data. There were some issues with that when we were collecting data in terms of patient files. So all these patient files who are being screened should be in a digital system. And a planning committee, so the same committee that would have been involved in this pilot project, it's important that these experienced persons be involved in the rollout in the future, because again, some of these challenges and the recommendation, they will be involved in, better rolling out this at a more national level. The next steps for us would be collaboration with the Ministry of Health. So we're doing that right now, where we're going to roll out primary HPV screening for the country. As I said before, we're using a gene expert. It is expected to roll out next year. And again, all of this is, it is the accredited and recommendation internationally with regards to screening. And some countries, just to mention, like Bangladesh and those places in rural settings in other countries, there are patients who are not able to get to a doctor. And there are lots of studies coming out now with HPV testing and self-testing kits. So once we strengthen our vaccinations and we have data on this, that will further decrease our cervical cancer rates, because patients can self-test with these kits in the future. I think that's the end of my presentation. I don't know if you're taking questions now at the end or via message. Thank you very much.
Thank you very much for that presentation. The next speaker will be one of our residents, OBGYN in Nassau, Bahamas, Dr. Terrell Carey, and he will be speaking on the knowledge, attitudes, and practices towards the human papillomavirus vaccine amongst physicians throughout the Commonwealth of the Bahamas.
Okay, good morning, everyone. I'd like to thank the hosts, Dr. Sinqui and the University of the West Indies, Dr. Blake, and other esteemed guests that are here for the opportunity to present my research on the knowledge, attitudes, and practice toward the human papillomavirus vaccination amongst physicians throughout the Commonwealth of the Bahamas. So on this very brief agenda, I've had to cut down a lot of my results just so that we can get through it in 10 minutes. but I'll be happy to answer any questions and add in any details at the end of my presentation. We're just going to go through the introduction, the intent of the study, the methodology, cover a few of the results, have a brief discussion, and discuss some of the limitations and some of the recommendations, and we'll close, and I'll list some acknowledgements. So according to the World Health Organization in 2019, HPV is the most common viral infection of the genital tract, and an estimated 290 million are infected worldwide. The persistent HPV infection with the high-risk genotypes, as Dr. Vijay mentioned in his previous lecture, it causes virtually all cervix of the cancer. If you accumulate all of the high-risk HPV types, it may account for about 99.7% of all cervical cancers worldwide. That being said, cervical cancer is the fourth most common seen cancer in women, with an estimated 570,000 new cases worldwide in 2018, representing 70.5% of all female cancer deaths. And in countries such as ours, it accounts for over 85% of cervical cancer deaths every year. So in the Bahamas, particularly, the population of women that are over the age of 18, which approximately accumulates about 152,000 women, are the highest risk for developing HPV-related cancers, with cervical cancer being at the forefront. And the current estimates indicate that approximately 29 women are newly diagnosed every year in the Bahamas, and about 23 women will die, based on recent statistics. And cervical cancer is about the third most common cancer in Bahamian women, and second if you only include the age group 15 to 44. In the Bahamas, we introduced the National HPV Vaccination Program in 2015, which of note is almost about 10 years after the vaccine was approved by the FDA. The primary referring agents are noted to be practicing physicians, and that's why the study was geared toward inquiring them as to what their knowledge of the HPV vaccine are and how do they practice, how do they refer, and what is the current barriers to vaccinating the population to address this national health burden. So we know that the Bahamas has an unacceptably high incidence of cervical cancer, which is a highly preventable disease through advances in screening, as mentioned in the previous lecture, and there's many ways of doing it, and also through vaccination. And there's overwhelming evidence has been well established linking high-risk HPV types to cervical dysplasia, as I mentioned. And as I mentioned again, that the FDA approved it in 2006. And the purpose of the study was really to just determine the baseline knowledge of attitudes and practices amongst physicians that are practicing throughout the Bahamas. So quickly, the objectives, just to determine physician knowledge, the physician attitudes and practices, and this is including their ability and their reasoning for referring and likelihood of referring patients for vaccination, and to assess whether patients' socio-demographic profile, such as their religion, their specialty that they were associated with, as well as the level of practice, whether they're SHO, registrar, consultant, and the numbers of years of practice. All of these were asked in the questionnaire in terms of trying to determine what factors were barriers and what factors were favorable for promoting vaccination. The location. So it was a convenient sample, only mainly sent to physicians that are practicing throughout New Providence Island in the Bahamas. It didn't encompass the other family islands, mainly the Agape Medical Center, South Beach, Elizabeth Estates, etc., Princess Margaret Hospital, and some private physicians were also selected randomly to participate in the study. The study formulation, the proposal was prepared from January 2020. Ethical consideration was considered on the 20th of February and approved shortly thereafter. However, COVID, as we all know, came amongst us, and we had to readjust our approach and go with a self-administered online questionnaire, which was done via SurveyMonkey. And this distribution of the study was done from April 2022 to May 2022. And then in August, the descriptive and inferential statistics were analyzed. So this was how the sample size was determined. And it was determined that we needed about 81 physicians, and we got a total of 87 that participated and completed the survey. Oh, and just to note, it was a 31 questionnaire, a 31 question questionnaire, and basically, as I mentioned, it was delivered online. So in the interest of time, we'll try and get into some of the results. So based on the male and female demographic, we had a 32.2% male participation and a 67.8% female participation. And these are all physicians, as I mentioned. These are the age ranges. And the next slide will just show you the current level of practice, which would be your interns straight to your consultants. And I also had demographics on private only and private and public physicians. So the years of experience was also included in the research, as we felt that the amount of years that the physician was practicing may influence their knowledge, attitude, and referral practice. So again, there's some demographics to the specialty. So, we tried to gear the study toward patients who more would see patients in the 9 to 26-year age range, and female patients and male patients, as both of them are recommended to be vaccinated. But we did include anyone who was willing to participate. We did include them. And as you can see, there's a lot of outliers for the subspecialties, but the main purpose of the study is going to be focusing on pediatrics, obstetrics and gynecology, family medicine, and general practice, as these are the specialties that typically will encounter the patients that really need the vaccine. So in terms of knowledge base, so just some simple basic questions about HPV. Does HPV infection have an impact on cervical cancer prevalence? As we mentioned, yes, it does. And 94% of participants did respond correctly. A few of them did not respond for reasons we couldn't really understand, but generally speaking, they got this question right. In terms of knowledge of the high-risk HPV types, which there are many, 16, 18, 31, 33, and 35 were the correct ones that were listed on the study. And you can see that 16 and 18 were generally acceptably correct, about 80 to 81% of physicians got that correct. But when you talk about the rarer types, such as the 31, 33, and 35, there was a little less acceptable knowledge that those existed. And this is important for HPV vaccination selection. As we know, some HPV vaccines will cover 2, some will cover 4, some will cover 9. And you need to have an idea of what vaccine is important for your population. So in terms of how many doses are recommended, again, when I made this study, the research questionnaire, things had changed. Things are always evolving. And there were initially 3 doses, but they then went down to 2 doses for the younger population between 9 and 15. And they found that they only required 2. So I included both answers as correct. And if you look at the summation of the 2 and 3 doses, 87.8 did actually get this question correct. And just to mention that the 3 doses really recommended for patients over 15 and also HIV patients, immunocompromised patients. So in terms of, let me just check on the time. All right, so current recommendations are that girls as early as 9 should re-offer the vaccine, which most of the participants did get correct, over 80%. And then also when we asked about boys between the ages of 9 and 16, most of the participants did answer correctly that they should receive the vaccine. And can HPV be given safely during pregnancy? Now, this was an area of contention. Quite a few of the physicians did respond that they were not sure. And this is an area that we can focus our education on, because HPV is actually not recommended to be given during pregnancy. Which HPV vaccinations are available in the Bahamas? So just for knowledge base, that Gardasil 4 is available at the National Vaccination Program publicly. However, Gardasil 9 is available privately only at a paid cost. So both of these answers were correct. And you could see that there was some lack of knowledge. There was not a lot of confidence that these vaccines were available. Cervarix is not available. And quite a few participants did think it was available. So again, another area. These are overall knowledge scores by specialty. And as you can see, most specialties include, when you exclude the other outliers, they did get greater than 70%, which is what our cutoff, and most other studies in the literature review did use 70% as a cutoff for adequate knowledge. So the following few slides will just talk briefly about the attitudes in practice. Typically, Preteen males or females should receive the vaccine. Most participants agreed. I'm confident referring the vaccine. Most participants agreed. I circled this area here. Again, a difficulty seeing the screen. Right, so offering adolescents will increase the likelihood of early sexual exposure. There was some discrepancy in this question, and it might be an area of contention for referral. Again, preteen males should receive the vaccine. Number one is strongly agree. And so most of our physicians do agree that the vaccine should be given to males. All right, so I'm going to have to go through, because we're running out of time, that basically in our discussion, we found that most physicians who participated had adequate knowledge. More than 70% of physicians answered the questions correctly. And 100% of physicians were aware that HPV did in fact cause cervical cancer, and 93.1% were aware that a pap smear is still recommended even after vaccination. So some questions that were answered incorrectly that are areas for CME and education. Pregnancy, as I mentioned, is not recommended, and the less familiar types of HPV 33-35 should need to be educated. As Dr. Vishal mentioned, that 45 was a little higher in areas such as Barbados and then also in other Caribbean territories. So healthcare provider recommendation is consistently identified on the literature review as mentioning several barriers that increase HPV rates. So some of these things include lack of knowledge, access barriers, parental beliefs, and religious beliefs. And in our study, we found that availability of vaccine was actually the most common perceived barrier. One of the limitations I'll mention before I close is that the external validity of the findings and based on the attributing to other family islands would be limited because the study was only performed in Nassau and New Providence. And clear areas for education, groups who should not receive the vaccine, the age that are most affected to vaccinate, benefits of male vaccination, and the vaccine availability in the Bahamas. And this can be accomplished through various CME targeting the physician groups that we mentioned. So these are my references, and I just want to say thank you again, and I'll be willing to answer any questions that you may have.
Thank you very much, Dr. Carey, for that presentation, that timely presentation. So we're going to move on to the next speaker, which is Dr. Pintard, also an OBGYN resident in Nassau, Bahamas. And he will be speaking on the factors affecting the reproductive ambition of women living with HIV at the Infectious Disease Clinic in New Providence.
Good afternoon, everyone. My name is Dr. Pintard, and my research today that I'm presenting, factors affecting the reproductive ambition of HIV-positive women in the Infectious Disease Clinic in Nassau, Bahamas. My advisors were Dr. Tucker Carr, Dr. Forbes, and Dr. Frankson. So I have nothing to disclose. Reproductive health is defined by United Nations as the state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity in all matters relating to the reproductive system and to its function and processes. It is essentially a fundamental part of the family unit and is a basic human right. That being said, it was pretty much the core of my rationale for doing my presentation. In accordance with the World Health Organization, there was a mission put forth back from about the Millennium Goals that pretty much stated that they wanted to ensure that there was equitable sexual and reproductive health rights for all. And they had identified several at-risk groups, persons living with HIV being one of those major groups. This was essentially brought forward into the Sustainable Development Goals, in particular Development Goal 3.3 and 3.7, which speak to essentially ending the epidemic of HIV and respectively then ensuring that there was access to sexual and reproductive health services for all individuals, especially these at-risk groups. So my objective in particular for this study were to identify any factors that were positively or negatively affecting persons, women living with HIV's right to reproduce. We want to know if the timing of when persons contracted HIV somewhat impacted their choice to have reproductive ambition or not. And we just wanted to find out if there was any knowledge or understanding among these women concerning safe practices and minimizing vertical transmission that was somewhat of a gap or wasn't being met. The methodology in particular, this was a quantitative design study. It was a validated closed-ended questionnaire. And it essentially was a compilation of questions from studies run by Agbo and Shifarov, which are essentially African studies, with some original questions that were added in by the researchers. It covers 6 domains, and the information remained essentially confidential, and there were English and Creole versions available for patients at their convenience. The inclusion criteria were women who were diagnosed with HIV infection that were attending the infectious disease clinic that were between 18 and 49, even though reproductive age is essentially considered 15 to 49. We kind of wanted to veer away from the confidentiality and consent issues that would have to be undertaken in regards to 15-year-olds, 16-year-olds, persons under 18, and women who either spoke and understood English or Creole. Data was essentially collected after persons had been screened at clinic. They were asked to participate, and they were given the option of answering the questions independently or having someone assist them with the answers in regards to if they were having troubles reading or writing. The questionnaires were then signed, and the consent forms were separated from the questionnaires and logged separately. It took approximately a year to collect the data, and approximately 60 questionnaires were completed through convenient sampling. The data was then entered into Excel and analyzed through SPSS. And some of the results is where we're at right now, so we'll speak about that. So the first domain that we looked at was demographics, and we see that the majority of our individuals were Bahamian, essentially 70%. And about 11% of the persons that answered the questionnaires were Creole or Haitian. The majority of persons in regards to their marital status was single, with about 22% being married and others being divorced and widowed. We looked at the demographics some more, and we saw that about less than 50% of individuals were full-time employed. And overall, almost 60% of our individuals were living in households that brought in less than $1,600 income. So for the most part, a lot of our individuals were on the lower socioeconomic status. And in general, we were able to keep within our inclusion criteria. Our youngest person was 20 years old, and our oldest person being 49. With a mean age for our individuals being about 33 years old. So then we looked at HIV characteristics, and each one of these domains had significant amount of questions, but we're going to delve more into the more meaningful results that we came across. And in this regard particular, we saw that persons who were living with HIV spoke about who they informed of their HIV status. And we find that even though there were different areas where persons spoke about, informed either their immediate family and spouse, or spouse only, when you looked at it overall, there was almost 90% of individuals who had spoken to somebody about their HIV status and included their spouse in their circle of persons who they trusted with that. Sorry, not 90, 70. So moving on with HIV characteristics, we also see, which is encouraging, most of the individuals that filled out the questionnaires were adherent to the antiretroviral medications. However, and most of them considered themselves to be fairly healthy. Essentially, about 80% of our individuals felt that they were either in good or excellent health. However, we did ask about things like support groups in helping with emotional and mental health, and most individuals had never even been exposed to any type of support group, essentially only about 4 individuals in total. We looked at reproductive features, and we see that for the most part, in particular, I have here highlighted in yellow, persons who had already been aware of the HIV diagnosis still had attempted pregnancies, and this was up to 74% of our individuals, which is kind of telling, saying that for the most part, it didn't seem as though HIV diagnosis kind of deterred people from getting pregnant or attempting pregnancy. And overall, we looked at the entire cohort of 60 persons, and about 45% of our individuals overall wanted to get pregnant. So we move on to their reproductive choices, and we see that the persons gave their different reasons. Those that 45% gave their different reasons for wanting to have a child moving forward. And most of the individuals wanted to have a child because either their partner wants a child or they felt that they were healthy enough to have a child. We looked at any perceived social pressures, and this is one of the key points of the study that I was hoping to look at. I want to make sure that the reasons for persons not wanting to have children or wanting to have children were their own and not something extrinsic as opposed to something intrinsic, because this is a right and it should be every woman's right. So we saw that most persons felt that they never really experienced any discrimination in relation to their HIV status. And even those that did experience it, about 25% experienced rarely. Of note, there were about 5 individuals who felt that they felt discriminated against because of their HIV status, often or technically always. Also, we saw that a lot of women felt that there was some perceived that their partner also wanted to have children, and this was about 54% of the individuals who wanted to get pregnant. They felt that their partner wanted them to get pregnant. In regards to perceived community pressure, about 62%, 63% of individuals felt that there was no real community pressure about them getting pregnant. At the same time, about 7% felt that there was pressure, and almost 30% were unsure whether there was pressure or not. So we looked at the person's knowledge of vertical transmission and their knowledge of the HIV progression overall. And we saw that for the most part, persons were not really aware of their CD4 count. At the same time, we are in a resource-limited region, and the reagent for CD4 count was often not available. We saw better results with viral load awareness, where we saw more individuals were aware of their viral load awareness, essentially about 70, almost 72%. In regards to the questions pertaining to vertical transmission, whether persons had reproductive ambition or not, we saw that in general there was an affirmative answer. We'll talk a little bit more about that in our discussion. And overall, even though persons felt that there are safe ways to go about getting pregnant without getting their partner infected or infecting their child, most individuals, over 50%, either seldom or never used condoms. So the last domain was in regards to clinical services, and persons were asked if they were interested in formal sessions in regards to sexual and reproductive health. And for the most part, individuals said somewhat interested, but we did see that overall, individuals were very interested in sessions on how they could have HIV, so how HIV positive persons could have children safely. And when asked how they would, what type of venue they would prefer to have this in, it was found that most of them would still prefer a more private individual counseling, and about 25% would have preferred to have a women's group, a focused women's group. So did we meet our objectives? Essentially, objective number 1 was to identify if there were any positive or negative factors affecting women's right to procreate. And there were some strong associations. In particular, we found that individuals who did not want to get pregnant came from lower socioeconomic status. They tend to have more unwanted pregnancies. So these were not statistically significant, but they were essentially noteworthy. We also saw that persons who did not want to get pregnant tended not to disclose their status to their partner, whereas persons who want to get pregnant disclose their status more often. So statistically significant was that, well, 48% of our individuals provided information about their future pregnancy, about wanting future pregnancies. And in 90% of the individuals who had reproductive ambition, they involved their partner in their group of persons that they disclosed. Whereas persons who did not have any reproductive ambition, only about 60% of those individuals involved their partner, showing that communication with partners and their partner being involved in the decision tended to be a major factor in whether persons want to have children in the future or not. Other statistical significant relationships were that, for instance, 55 individuals provided information to whether they perceived that their partner wanted to have children. And for the persons that had reproductive ambition, about 85% of those individuals said that their partner also wanted children. In regards to persons who didn't have reproductive ambition, only about 30% of those individuals felt that their partner wanted to have children. The extent to which participants felt their partner actually wanted the reproductive ambition, essentially saying that if they felt that the person either wanted the child but didn't really want it a lot, persons who had reproductive ambition felt that their partner wanted to have a child very much, and persons who felt that they did not have any reproductive ambition at all. So participants who didn't have reproductive ambition, they essentially felt that their partner didn't want any children at all. So we're coming down to the end. Statistically, other statistical significant findings was that about 59% participants commented on whether they had a perception that there was social pressures about them having children. And of the 27 persons that had reproductive ambition and answered this question, 22% of them felt that society would think that something was wrong with them if they didn't have children. As opposed to the persons who didn't have reproductive ambition, most of them felt that that there was no pressure from the community for them to have children. Only essentially 3% felt otherwise. So in regards to our second objective, to determine if there was any timing relation with whether persons had reproductive ambition or not, we had approximately persons who had been diagnosed 1 month prior to filling out the questionnaire, and persons who had been diagnosed 17 years prior to filling out the questionnaire. And the average range was about 10 years for persons who had been diagnosed. And overall, it was shown that there was no real relation between being diagnosed with HIV or time of being diagnosed with HIV and wanting reproductive ambition or not. This is in contrast to actually one of the studies that came out in Montego Bay around 2019, I believe. And they showed that persons who had been diagnosed with HIV for shorter periods of time tended to have a higher incidence of wanting children. Our last objective was in regards to whether persons' level of knowledge or understanding concerning safe sex practices and minimizing vertical transmission was related to their reproductive ambition. And for the most part, there was no statistically significant finding in regard to this. And even though persons overall tended to have an understanding and all of them agreed correctly with the questions that were asked, it was actually found that persons who had no reproductive ambition tended to agree more strongly, possibly suggesting that they'd already been through a number of pregnancies and were pretty much comfortable with understanding what vertical transmission was and how to avoid it. So overall, in conclusion, we find that persons with reproductive ambition tended to include their partners in their group of individuals that they informed about their reproductive status. They felt that their partners wanted children very strongly, and this influenced their reproductive ambition. And some social pressures were noted, but it was not a significant finding in the study. Most persons were aware of vertical transmission and understood what it meant. And even though persons knew what safe practices were, we found that a lot of individuals, like I said, almost 50% were using condoms seldom or not at all over the last 12 months. Limitations in regards to this study were that, first of all, there was no accurate number for the population Based at the time of doing the study, there was a little over 1,200, I think 1,227 reproductive age women living in the Bahamas between the ages of 15 and 49. However, a large majority of those individuals tended to attend private clinics. And this again was during the time of COVID. So a lot of persons were lost to follow-up, coming to clinic quite infrequently. So it was a bit of a difficult task to collect questionnaires. Around about 40 or 50, around about 40 individuals, or when we had gotten to about 40 questionnaires, we had found that we was starting to get recurrent patients. Patients would tell you that they had already seen me or they had already spoken and we already filled out the questionnaire. It was a small study, so it was not a lot of power. And again, because we had difficulty trying to figure out what the sample size was, that tended to take away from the power as well. There was apprehension in the study group, but not so much for the English-speaking individuals, but rather the Creole-speaking individuals, even though they were given a possible translator, as well as a translated version of the questionnaire and consent form. There were no strictly Creole-speaking individuals that actually filled out the questionnaire. So I actually spoke about this already, and just want to say that essentially the way going forward would be to consider couple-centric approaches to reproductive counseling for persons living with HIV, as it seems that persons tended to involve their partners very strongly in how their partners felt about having children tended to affect them very strongly. We need to possibly implement annual sensitivity training for healthcare professionals, especially in obstetrics and gynecology. Even though a large majority of the individuals didn't feel any discrimination, there were 5% of our individuals that did feel that way. And in particular, there was a participant who spoke about having a traumatic event within the hospital, in which she had heard a healthcare professional walking down past a hallway saying, "Why is she still getting pregnant?" And that kind of stuck out with me in particular. And even though she was one person is reportable, and it's something that needs to be corrected. And we possibly need to incorporate strategic methods to encourage feedback from our Creole community. This is a subset that tends to be marginalized, and not strictly because of the demographics of them, and not strictly because of the healthcare sector, but possibly a combination of both. I want to thank my principal investigators who helped me with the study. And in particular, I want to thank Ms. Curtis and Ms. Glennice Johnson, who work at the Infectious Disease Clinic, and Dr. Alexander, who helped out with a few of our questionnaires. These are my references, and I thank you all for your attention.
Thank you again, Dr. Pintard. Dr. Franklin Saunders, again, another OBGYN resident from the Bahamas campus, and he will be speaking on the comparison of Bishop score and modified Bishop score in predicting the outcome of labor inductions performed at the Princess Margaret Hospital, Nassau, Bahamas.
Good evening, everyone. I was just making sure of the time. Again, thank you for the introduction and protocol having been already established. I just want to thank the presenters for allowing me to speak and present my presentation at this time. Again, the topic was comparison of the Bishop score and the Bishop score with modifiers in predicting the outcomes of labor induction performed at the Princess Margaret Hospital. This is the overview. We're going to be looking at the objectives, the introduction, and trying to keep the time as much as possible. We'll go through as briefly as we can, but try to get as much as we can from the study itself. So the purpose of the study was to assess the use of the Bishop score in relation to obstetric outcomes of labor induction and term mothers presenting to the maternity ward. Now, this study had came up on an interesting day on the ward round with Dr. Varunda, my principal investigator. At the time, we were assessing preeclamptic patients or patients with hypertension, and we were talking about methods or the various methods of calculating Bishop scores. And And so this is how we came up with the study where we wanted to look at determine which one was a better predictor of assessing the outcome of labor, which one was a better predictor of assessing normal spontaneous vaginal delivery. The objectives again further go on to describe this medical socio-demographic profile of the study participants, also to assess it again, which was the better of the two scoring systems, to determine the frequency of the indications for induction in the Bahamian population, and also determine the incidence of induction of labor during the study period. So in terms of our introduction, just a brief overview of how the Bishop score was developed or where it came from. It was discovered in 1964 by Dr. Edward Bishop, who developed a pelvic scoring system to predict the likelihood of obtaining a successful vaginal delivery as a result of elective labor induction. The original Bishop score, and we will see that even if you look through the literature, you will see that there's been many adaptations to the Bishop score itself, many persons trying to improve on it, as well as many persons trying to see which factors were more important in determining the outcome of labor. So it looks at basically 5 overall features of the cervix, and most OBGYNs or all OBGYNs actually use it as a part of our clinical assessment. We assess whether how dilated the cervix is. We also look at the effacement, also the position of the cervix, the station, and the consistency of the cervix. So this here was the overall genesis of the whole entire study. Here we see the original Bishop score, which looked at, again, the position, the consistency, effacement, dilatation, and the station. And we can see that overall, when we look at the scores from 0 to 3, for depending on which factors or which factors were being assessed, you can get a score as high as 13. However, in the original Bishop score, what Dr. Edwards found, Dr. Bishop found was that a score of greater than 8 was able to predict the successful likelihood of obtaining successful induction. A score of 10, however, would normally predict whether the patient would go into normal spontaneous vaginal delivery on its own, as well as a score of less than 8, or some would say less than 6, would sometimes mean that that his patient was unfavorable and some cervical ripening agent would be needed in order to have a successful induction. Now, what we attempted to do was look at the modifiers themselves. Here we have different modifiers. We would add or subtract points depending on which one of these modifiers were present. So if the patient was pre-eclamptic, we would subtract 1. If the patient had previous vaginal delivery, we would add 1. If the patient had previous vaginal delivery, we would add 1 as well. And then here we would subtract 1 for each of the following features, depending on which one would give, I guess, a more favorable or more negative overall predictor to having a normal vaginal delivery. So we just wanted to see which one of these scores, by applying it to each patient, which one of these scores was overall a better predictor of labor success or labor failure. So in terms of the Bishop scoring, an unfavorable score, as we said, was less likely to have unsuccessful outcomes, resulting in cesarean section delivery. And this can result, as we know, in increased morbidity and mortality. And again, we know that overall goal right now of medicine right now is to try and decrease litigation and basically mortality overall, to try and have better outcomes for our patient. So the objective or the aim was to basically try to see if there was some clinical means of basically trying to determine which one of these would be able to predict the better score and help to guide in our management. When we look at the rate of induction of labor, we see that this is steadily increasing. And again, along with the rate of induction, we see that there also is concomitant or morbidity as well as mortality. So in the developed world, there's basically an induction rate of 1 in 4 of pregnant women in industrialized nations. However, the scoring system has been met with mixed reviews. Some studies showing that it is not a good predictor of labor outcomes, while other studies show that it is very good in terms of reliably predicting outcome of labor when we especially look at higher scores. But when we compare this or the Bishop score itself with other prognostic tools, it still far outperforms the competitors. And again, we have about 4,000 to 5,000 live births per year. So this again helps in terms of us figuring out or trying to get to the overall objectives of our study. These were our inclusion criteria. Term mothers greater than 37 weeks. Again, just general criteria in terms of any induction, unremarkable non-stress test, somebody who has had a plan, who has not had a previous cesarean section, that sort of thing, as well as people who meet the overall criteria or indication for induction, as we know, postdatism, failure to progress, fetal distress, etc. So the methodology, the study was basically a descriptive study of term mothers with a gestational age of 37 weeks or more, who presented to the labor ward. The general age group would have been, or the age group would have been ages 18 to 44. And the study was conducted between April 1st and 2021, as well to July 31st, 2021. This was also during the period of COVID. So we did have some challenges as well. The data sheet was used to basically uptake patients' demographic as well as clinically assess the Bishop score. And the scores were basically tallied on that, and basically the outcome of those deliveries or those inductions were uptake. This was just a sample of the collection data form. I'm just moving through of the non-pertinent information at this time. All files are confidentially, as we know, and the files were basically identified or analyzed using a version of SPSS. So, okay, so in terms of descriptive statistics we used, data was, Sean, you can. Okay, so when we look at the overall results, there was 140 pregnant mothers reviewed for eligibility for induction of labor, and 127 met the inclusion criteria. Our sample size was calculated, and it was 125, so we were within the target population. This was just some of the data collected. The age range, which showed that the overall or the mean was 27.9. The overall parity was, or the median parity was 1, which showed that, most of the patients were not multiparous per se. We also looked at the indications for induction of labor. Again, postdatism or late term, which was more adequately described. The patients were the most common indications, followed by hypertensive disorders. In terms of the Bishop scores, we see overall distribution for the original Bishop score with a median score being 5. However, with the modified or the Bishop score with modifiers, the median score was like 5.2. The overall induction to delivery time was 14.1 hours, with a minimum being 2.8 hours and the maximum being 56 hours, which was a bit on the extreme side. The mode of deliveries, again, normal spontaneous vaginal delivery occurred in 76% of the patients, with sections being 24%. In terms of the results, either model had a 76.4% correct classification when cross-tabulating for predicted versus observed mode of delivery. And the results were statistically significant predictor, or the Bishop score itself was a statistically significant predictor for outcome of labor in the study. In terms of the overall induction rate, we had an induction rate of 11.9. But when we compare this to the induction rate in the UK, as well as other industrial countries like the US, it was 23%. But we know that this rate may have been hampered by the occurrence of COVID, which truncated some of our services. And when we look at other countries in Africa, we see that they have a lower induction rate, which is 2.9 and sometimes 11.5. But this may be due to resource limitation. In terms of our demographics, the age was representative of most studies, which was 27.9. The party, however, did not show a positive correlation with induction success in this study. However, in other studies, we know that with advanced party, it tends to lend credence to successful outcomes in terms of labor. Our results were also concordant with existing studies regarding a positive tendency through the addition of the modifiers to show a need for ongoing study. So basically with the modifiers, it didn't have as well a fit as the Bishop scores in predicting the overall outcome, but it did show, however, a positive correlation. And again, the participants' mean Bishop scores were 5, again, 5.2, and the effacement was seen to be the most important predictor of cervical or normal delivery. In terms of conclusion, the Bishop score showed a positive correlation with induction to delivery time, and was more statistically significant with the original Bishop score than with the ones with the modifiers. It has been studied extensively and can be considered a standard tool in the practice of induction. However, the Bishop score with modifiers did not outperform the simplified or the original Bishop score, and it showed need for a larger study to define a study subset and to possible need to a distinct study group. Hypertensive disorders remain the most common cause of induction of labor. I mean, the second most common cause. Our limitation was the ease of accessibility of medical records, may have limited the study. There were incomplete data entry in some of the patients, and so there was some limitation in that regard as well. The number of inductions may have also been limited during the period of time, as we said, COVID had just started. So some of the services were a bit truncated and the number of inductions had decreased. There were different methods of induction, but overall, the most common method was prostaglandins, with misoprostol, and the sample selection and need for a possible larger size may have been a limitation. Standard protocols in regards to cervical ripening versus induction of labor. So recommendations would be for a larger study size or extended time period, the implementation of a Bishop score checklist for all induction patients, and a clear consent form for all induction of labor, digitization of data collection for patient data for ease of accessibility, and establishment of induction of labor protocol for our maternity unit. These are my references, and I thank you. I acknowledge my supervisors, as well as all the persons from the obstetrics and gynecology department who have assisted with this project. Thank you.
Okay, so we're going to move on to the final speaker of this segment, Dr. Azaria Claire, also a OBGY resident from the Bahamas campus, and she will be speaking on the role of second trimester uterine artery Doppler in predicting preeclampsia and intrauterine growth restriction in high-risk Bahamian residents.
Good morning. Thank you, Dr. Ijoma, for that introduction. Thank you for allowing me to present my research, or our research. My name is Dr. Zaria Claire. The principal investigator of this study was Dr. Brenda Sakakar. Okay, so just a brief outline. We start off with the objectives, followed by a brief introduction and the methodology, followed by the results, the conclusion, acknowledgements, and then references. So the primary objective of this study was to determine the value of uterine artery Doppler ultrasound as a screening tool to predict the complications of impaired uteroplacental blood flow, inclusive of the development of preeclampsia and fetal growth restriction among high-risk Bahamian women. Another objective of this study was to determine which parameter of the uterine artery Doppler velocimetry was most predictive. So the introduction. Preeclampsia is a hypertensive disorder of pregnancy characterized by elevated blood pressures and proteinuria that develops after 20 weeks gestation. The etiology of preeclampsia is a popular topic among researchers, however, it remains undefined. It's believed that a genetic predisposition leads to the inability of trophoblasts to invade the myometrium. An abnormal Doppler flow is thought to be linked to increased risk of adverse pregnancy outcomes, inclusive of preeclampsia and IUGR. Now, the complications from preeclampsia have led to increased rates of maternal mortality globally. However, these increased rates are considered preventable. Worldwide, hypertensive disorders in pregnancy were ranked second among the most common causes of maternal mortality. Current methods used in screening for preeclampsia have proven to be unreliable. There have not been preventative measures developed for high-risk patients with an abnormal uterine artery Doppler blood symmetry. However, testing is beneficial in identifying low-risk patients based on normal uterine artery Doppler blood symmetry results. Low-risk patients would then have fewer antenatal clinic visits, leading to a decrease in the healthcare cost and burden on our healthcare system. A study conducted by Axtino et al. Supported this concept. In their study, they enrolled about 100 pregnant mothers in their second trimester of pregnancy. Abnormal uterine artery Doppler blood symmetry was found to be related to a positive predictive value of 35% for preeclampsia or IUGR development. The negative predictive value, however, was approximately 98%. The authors concluded, therefore, that normal uterine artery Doppler blood symmetry found in a woman with high risk factors during her second trimester of pregnancy may be considered low risk. She was therefore a candidate for less intensive antenatal care. The use of uterine artery Doppler blood symmetry was more efficient in predicting preeclampsia and IUGR than using clinical risk assessment alone. Studies have shown that the traditional method of prediction, though through the evaluation of maternal history, allowed for identification of approximately only 30% and 20% of cases that developed into early and late preeclampsia, respectively. Blood pressure and proteinuria were also inefficient predictors of adverse fetal or maternal outcomes, as reports have suggested that hypertension and proteinuria may be absent in patients diagnosed with preeclampsia. Now, according to the Indian Journal of Obstetrics and Gynecology Research, in early pregnancy, uterine artery Doppler blood symmetry typically demonstrated an early diastolic notch with low endostaltic velocities. The latter, however, usually disappeared by 24 weeks of pregnancy, and by the third trimester, end diastolic velocity increased to continuous forward flow throughout diastole. By mid-second trimester, should the end diastolic flow remain low, or should early diastolic notching persist, this was noted to be predictive of preeclampsia and IUGR development. In some cases of severe placental dysfunction, end diastolic flow was also noted to be absent or even reversed. Now, the optimal age of gestation for carrying out the uterine artery Doppler blood symmetry among pregnant women has been widely debated among researchers. Most studies have suggested, however, that pregnant women within their second trimester can have these scans done during their normal routine at fetal anomaly scans, which is given during the second trimester of pregnancy. So several factors affect the resistance to blood flow within the uterine arteries, and these include hormone fluctuations, BMI, ethnicity, as well as the maternal pulse. The resistance index and pulsatility index measure the impedance of uteroplacental blood flow, which is then transmitted to the uterine arteries. Now, in 2015, Young et al. Performed a cross-sectional prospective study on pregnant patients between 12 to 40 weeks to date. They investigated the mean normal values for uterine artery RI and PI. The results showed that as gestational age increased to 34 pregnancy, the uterine artery PI and RI values decreased. This increase was secondary to the reduced uterine artery resistance, which occurred after trophoblastic invasion. Now, the specific parameter of uterine artery Doppler blood symmetry that is most efficient in the prediction of these adverse pregnancy outcomes is widely debated. In their study, Kung et al. Defined a notch as a decrease from the highest velocity during diastole of at least 50 centimeters per second. They further reported that in comparison with late diastolic notching, the occurrence of early diastolic notching reflected vessel elasticity and a decrease in velocity during diastole. The results from their study also reported that early diastolic notching was a common occurrence in normal pregnancies during the first trimester. It was found to be present in up to 60% of women enrolled. When it persisted, however, it was also found to be associated with increased vessel tone. Beyond 19 weeks gestation, a subjective criterion was used to determine the presence of notching, and this was the approach that was used in our study. So the rationale for this research essentially is because there's limited concrete data found on the incidence of preeclampsia in the Bahamas. However, according to the Bahamas Confidential Inquiry into Stillbirths and Neonatal Deaths in first-week neonates in 2019, Bethesda, in 2019, there were a total of 3,561 deliveries, 2,828 of which were live births. Now, of the pregnancies resulting in live births, 0.1% were complicated with eclampsia, 1.6% with preeclampsia, and 2.7% with IUGR. Report indicated that there were no cases of maternal morbidity in any preeclamptic women that year. However, this was credited to the judicious utilization of magnesium sulfate. 33 stillbirths occurred at the Princess Margaret Hospital, and most of them had preeclampsia at the time of the stillbirths. The preeclampsia in developing countries like the Bahamas has proven to be more severe compared with other common causes of maternal death, such as infection. This has been attributed to the unpredictable nature and late presentation, rendering most therapeutic options in preeclampsia ineffective. So we hypothesized that there is an association between uterine artery Doppler velocimetry findings and impaired uteroplacental blood flow among high-risk Bahamian residents at 18 to 24 weeks gestation. And diastolic notching was hypothesized to be the most predictive parameter in the development of PET and IUGR. So briefly, the methodology. The target population was all antenatal women with confirmed singleton intrauterine pregnancies currently residing in the Bahamas. And the study population was antenatal women with high risk factors for preeclampsia and IUGR. And when we spoke about high risk factors, we limited them to prima gravidas, age over 41, hypertension, diabetes mellitus, and the list goes on. The exclusion criteria would be those with congenital anomalies, confirmed multiple pregnancies, premature rupture of membranes, prem labor, or intrauterine fetal demise. So the study was designed as a cluster sample with the intention to treat. We divided the entire pregnant population at PMH into a smaller high-risk group. The patients were chosen at random among these clusters from various public health clinics throughout the city to form a sample. And from this sample, we evaluated the uterine artery Dopplers and pregnancy outcomes in preeclampsia cases in high-risk pregnancies and used a combination of the Doppler ultrasound parameters to best predict preeclampsia among these Bahamian patients. The study commenced in January of 2022 and was completed by December 2022. The sample size required for the study was a minimum of 128 participants. So a questionnaire was completed by the participants confirming their demographics and comorbidities. The uterine artery Doppler studies were then performed as part of their routine antenatal care. All Doppler studies were performed at the Princess Margaret Hospital by the same researcher after being trained by a consultant radiologist. We define an abnormal uterine artery Doppler velocimetry as an elevated RI above 0.58 or equal to 0.58, and an elevated PI as above 1.30, or the presence of end diastolic notching, whether it be unilateral or bilateral. Study participants were separated into two groups, normal Dopplers, those with normal Dopplers and those with abnormal Dopplers. Both groups were followed up to delivery and early procurement. Information of the labor and delivery parameters were then obtained from their respective patient files and accounts from the labor ward. A diagnosis of preeclampsia was made based on blood pressure measurement and urinalysis. An IUGR was diagnosed at the time of delivery based on the infant's birth weight for that gestational age. So as far as data analysis was concerned, both descriptive and inferential statistics were carried out on the study data collected. So the results. This table just shows the frequency distribution regarding participants' risk factors for preeclampsia and IUGR development. And as you can see, the largest represented risk factor in our study was nulliparity, and this was followed by obesity and closely followed by a history of preeclampsia and a prior pregnancy. So this table simply shows the frequency distribution and valid percentages regarding participants' diastolic notching, the resistive index, the pulsatility index. Also included here are the mean arterial blood pressure, IUGR, and preeclampsia. Essentially, it just shows how many persons in the study had notching, how many had elevated RI, how many had a elevated pulsatility index. So in this table, we have the mean resistive index and pulsatility index of participants with preeclampsia versus the participants without preeclampsia. the difference between their means, and its statistical significance. Now, the results indicated that an elevation in the uterine artery Doppler parameters RI, PI, and the presence of end-diastolic notching, which is not shown in this particular table, were all observed to have a strong association with the development of preeclampsia. These findings were supported by multiple studies. One such example was by Adikime et al. They found a statistically significant association between uterine artery RI, PI, and the presence of notching, and participants with preeclampsia compared to women without the disease. And this was had a p-value of 0.005. The use of these parameters in the prediction of preeclampsia was also corroborated in a study by Muik et al., who reported a very strong positive relationship between RI and PI values with patients with preeclampsia in their second and third trimesters of pregnancy. So specifically, the table shows that the mean difference of 0.082 in the RI between those without preeclampsia and those with was found to be statistically significant. P was equal to less than 0.001. Our results again corresponded to the results from a study reported by Thakur et al. In their study on uterine artery Doppler velocimetry screening among high-risk antenatal patients between 28 and 24 weeks. They also observed that an increase in the uterine RI and a strong association was found with the development of preeclampsia. Now, the mean difference of 0.122 in the PI of those without preeclampsia and those with also differed significantly. This also agreed with a study by Kung et al. And Reddy et al., who reported that increased PI was a fair predictor of preeclampsia. So the next table shows the mean resistive index and pulsatility index of participants with IUGR versus the participants without IUGR. The difference between the means and its statistical significance. Overall, the results indicated an elevation in the second trimester uterine artery Doppler parameters. The RI and PI demonstrated a strong association with the development of IUGR. And again, it just shows the specific differences, the specific means of the RI and the PI as it relates to the development of IUGR. So this table shows a multiple logistic regression analysis regarding significant predictors of participants' preeclampsia status. So essentially, the multiple logistic regression was used to show the prognostic value of the RI for the development of preeclampsia. So it was found that the mean RI had a stronger prognostic value compared to the mean PI, which was a value of less than 0.001. And again, multiple studies had corroborated our findings. Just going to try to wrap up. In our study, the results also indicated that an end-diastolic notching shows statistically significant, very strong relationship with the development of IUGR. And using multiple logistic regression analysis regarding significant predictors of participants with IUGR, the end-diastolic notching had the better predictability than both the mean RI and the PI. Specifically, bilateral end-diastolic notching proved to be the most predictive for the development of IUGR. So in conclusion, this study demonstrated that the strongest predictor for the development of preeclampsia was the RI indices. And end-diastolic notching, however, showed a statistically significant, very strong relationship with the development of IUGR, thus was considered the best predictor for the same. The goal of our study was to develop a method to risk stratify antenatal women to provide them with a low-dose aspirin from early pregnancy, as well as to strengthen subsequent surveillance among these women. We were able to prove that uterine artery Doppler velocimetry may be used as a predictive tool among second trimester patients with high risk factors for developing preeclampsia and IUGR. Now, in the Bahamas, where resources are limited, while there is an ever-increasing amount of antenatal patients, this can be a very useful tool. With the implementation of the National Health Insurance Scheme, this may also be useful to stratify antenatal patients who can receive antenatal care from a general practitioner versus one who should be channeled to an obstetrician for high-risk care. The limitations of our study were limited by the small number of participants, the lack of ethnic diversity, as well as the use of a transdominal ultrasound technique as opposed to a transvaginal. And this was simply because of cultural sensitivity of the study participants. The strengths of the study, however, were that the study population was limited to high-risk pregnant women, and the same investigator and machine were used for all Dopplers. Special thanks to Dr. Verunda, the chief investigator, Dr. Frankston, Dr. Minnis, Dr. Graham, Dr. Burnett, Dr. Idaho, Dr. Juma, Nurse Mary Walker, the staff and the Department of the Public Health Antenatal Clinics, the staff at the Department of Obstetrics and Gynecology at the NIH. These are my references. Thank you.